Mukherjee is a pediatric neurologist, and even before pediatric neurology was so popular, we have been going to him with our pediatric neurology cases because he has done his training in Sri Chitra, where a strong cases of pediatric neurology in Kerala. So welcome, Shambhala. And we also have with us our esteemed Professor Shambhala Mukherjee, Professor of Pediatrics in Lady Martin Medical College, Delhi. And she pediatrics is her forte, and especially global developmental Delhi. We also have among here other favorite Professor Shambhala Mukherjee, who is the HOD of Neuropedicon of IPGMER. She's sitting there. So thank you, Shambhala. She's a co-convener of this workshop, and without her and without the infrastructure that we have been provided, it would not have been possible for us to hold this workshop in such a nice ambience and such a nice place. I also had Nash and a few of our colleagues who are also going to come, Shuri Basu and Dr. Shashwati Mukherjee, who is a clinical dentist, will be there with us in the hands-on session. So, and also Dr. Shah, who is the person organizing this, Dr. Kolkata Chatterjee, who is the president, Dr. Mehra, who is also one of the conveners of the whole conference, and I hope I am not leaving out anyone else. So, the most important to our new participants, because the workshop is called Global Developmental Day, is a new terminology. I won't say very new, but it is something we are still getting familiar with, and as we are evolving, pediatric neurodevelopment is an evolving science. Even more we are seeing it now, as I'm sure in my introduction. So that is why it is becoming very important to focus on neurodevelopment, because this is a foundation of all that we do later on in life. Starting from the first 1,000 days of conception, from the time a child is conceived, to about 6 or 7 years later. That is a period of fast neurodevelopment. And if there is a issue here, if there is a delay or a deviation, it is detected early, then something can be done about it in the adequate time, which will make a difference. If it is detected later on, and later on, even if you put in a lot of effort, then the results that we get will be less than what we do if you put an early effort or early intervention. With this, I again welcome you all, and I will do a short introduction to what we are wanting to do in this workshop. So he's been the driving force behind this conference and also this workshop. So without showing said, also it would have been difficult to arrange it. So and speech delay or contact. So what is the objective? Welcome, Dr. Lara. What is the objective of this workshop today? The learning objectives today are what is the concept of global developmental delay. What is it? How do we define global developmental delay? What is the epidemiology, which we have just talked about? What are the causes of global developmental delay? And how to approach systematically when we diagnose a case of, clinically diagnose a case of global developmental delay. Here, this will involve the clinical assessment of a child with delay, including how to objectively assess development by using tools, that is the formal assessment, both screening, mainly screening and also the formal assessment. How to investigate, so any approach means clinical examination, investigation. And then finally treatment, that will also of course be based on the individual cause of the delay. And of course every delay there can be a supportive treatment and there can be a definitive treatment. So again it will have to be individualized to the child. And the role of genetics is coming up in a very big way, and most of us are still grappling with how to go about genetic tests. Genetic tests are not easily available for proper advice. So we have a geneticist who is due to come with us, Professor Shashwati Mukherjee, who is a clinical genetist and consultant genetist to IPGMER in Kolkata. So she is going to enlighten us on that in the second half. We also have cases for you. Because what is a workshop without actual cases? It's like sailing to sea without having learned how to sail, not sailing at all, rather I would say. And then finally, post-life, there is a hands-on demonstration where we will have 3 stations in which one station will be on tools of development processes. Dr. Nilanjan Mukherjee will be there along with Dr. Jamshud Dash in that. And the other one is how to detect and do early intervention. And the third workshop will be on genetics. People don't know how to take a good family history, hereditary history, or inheritance history, make a pedigree chart. So I want all of us here, especially the postgraduate students, to know how to draw a pedigree chart. So those are the 3 stations that we have. So I will just define briefly because this is the opening talk. And the developmental delay, it is a developmental delay across several domains in children under 5 years of age, when the clinical severity cannot be reliably assessed. Most of these children need reassessment after a period of time. So why do we call it global developmental delay? Because it is still evolving. And that is why they are mainly under 5 years old. So beyond 5 years, whatever has evolved, maybe more or less more clarity, there will be more clarity in what the extent of the disability is, whether it is one domain or multiple domains, or whether it is cognitive associated or not. And after this 5 years time, I think we would know the progress of the disability would have evolved to meet the diagnostic criteria for intellectual disability. So in simple words, cognitive delay is an associate of global developmental delay. 2 or more domains of delay, the domains, that is gross motor, fine motor, speech and language, social and cognitive. That's an important domain. So cognitive delay has to be associated with 2 or more other domains. And after 5 years it is called global developmental delay, that is now the terminology. Beyond 5 years it usually goes into intellectual disability or intellectual disability, that is ID. They are called ID after that. So what are the diagnostic criteria? The cognitive delay or decline with delay in 2 or more areas of development is reserved for children under 5 years of age, and it may include older children who are unable to participate in formal assessment of intellectual function. All those can also be labeled as global developmental delay. So with this short introduction, let us start in the interest of time and keeping to time. Let us start our journey of this workshop. But before I do so, I would like to just have a quick one-line introduction of all the participants. So, starting from you, sir. Okay. You want to be louder? Please, for your release. Sir? Please tell us what you are doing.
I'm a third year resident in Developmental pediatrics.
Third year resident. So many postgraduate trainees.
Dr. Chojoti Ghosh from second year
You're also postgraduate training? Ames Delhi. Ames Kolkata. Kindly louder, please. Maybe I'm getting older. I'm sorry, our mic is not working here, so you just have to be loud. Mic actually.
third year GM resident, Neuropedicon.
Dr. Shulabna Dutta, third year DM resident, Neuropedicon. Second year PGMER.
Vishwajit Sarkar, third year PGMER. Manu Sarkar, third year PGMER. Dr. Shobhita Chirag, retired pediatrician and what also.
Never retired.
I never retired.
Dr. Neuropedicon Singh completed my post-graduation from ICH, currently posted at Swasthya Bhavan.
So, the other thing I am asking is I would take this opportunity to label yourselves. For example, 1, 2, 3. So, remember which number you have been allotted. 1 is for workshop number 1, which will be developmental tools, and 2 will be workshop number 2, which will be screening tools. 2 will be early intervention in delay, developmental delay, and 3 will be genetics, hands-on training in genetics. So remember, 1 is for developmental tools, 2 is for early intervention, and 3 is for genetics. So, what we do is, after 20 minutes, it's post-lunch. After 20 minutes, the group 1 will then shift to the second table, which will be group 2, and group 2 will shift to the third table, which will be group, and then the third table will shift back to group 1. Am I clear? Yeah, so everything is so to understand. So, I will ask you to call out 1, 2, 3 as per your sitting arrangement. Okay? 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3,
1, 2,
3. So on those who are coming later, when we are with a problem, we will have to get them which group. Remember your groups, so that the post-lunch session, we will then easily divide ourselves into the 3 groups. So with this, I come to the end of instruction, but Professor Postman, would you like to say 1 or 2 words?
Good morning. Respected dignitaries and faculties and students. So, at the outset, I must thank coordinator for organizing this workshop in our Developmental Institute, where there is a well-managed, well-run DIC clinic. Because DIC clinic in this disorder can play a great role. And we are also trying to establish, or already we have established, DIC clinic in every medical college, and it is going down to the district level also. And there are many colleges, as you have seen. Still, in my experience, I think genetic cause is the commonest cause. 30% are genetic. There may be Down syndrome, Turner syndrome, Rett syndrome, Williams syndrome, everything. But problem is that we are getting increasing number of acquired causes because of the severe blood disease, which are more prevalent in the district and sub-division hospitals. So severe blood disease are also leading to this acquired cause of developmental. And another point I want to stress upon that awareness of early detection, because intervention is the main thing which you can. Intervention requires our awareness, early detection, and then intervention, and because with this we can improve many children. And other cases, there are neurometabolic disorders where Indian replacement is being done. And you will be surprised to know, a few weeks ago, from our government side, we have given 17 crores for a child for Indian replacement. And also we are giving free of cost this Indian replacement in this center and other centers also. And so I think this program will be very successful. There are renowned faculty members and we will enjoy this program. Thank you.
দাদা একটু সরে আসুন।
So good morning everybody. Okay, so you might have noticed that the title of my topic was very vague. I just wrote global developmental need because I don't know what I'm going to talk about, what aspect of it. Anyhow, as an introductory talk, I will try to get into the subject, open the field for the next speakers to really keep it up seriously. And there again, Dr. Moshumi has set the ball rolling, so some part of my activity is already taken care of. Coming to start with the definition, as she has mentioned. Now I have to split up the definition. What is global developmental need? It is defined as number 1, significant delay. Number 2, not the word significant. Number 2, where in 2 or more domains of development, in whom? In children less than 5 years. These are the 3 major aspects. Why have I separated them? When I say significant, I mean less than 2 standard deviation from the expected at that age. And then the age group is less than 5 years. But the middle one, in 2 or more domains of development, here lies at that age, which Koshumi has already touched upon. Now, what do we mean by here? What are the domains?
speech, hearing, vision, all of these are domains. So if I just say 2 domains, it may be any 2 domains. Here comes in the caveat. If there is delay, say in motor development and vision, is that global developmental delay? Theoretically it should be. So, but there is a problem. Because what is the problem? We by convention know GDD is a precursor of intellectual disability that is there in our brain. So as she has rightly mentioned, some cognitive delay needs to be filled in. Now you might say, who told you that DDD has to be IDA? Because any other entity not taking in cognition, but our Bible here is the DSM-5. DSM-5 category puts 2 points here. One is the diagnostic criteria of GDD is a subcategory under ID. GDD has been filled in under ID. So you have to have a cognitive involvement. Secondly, the DSM-5 is clearly saying why GDD? Because though there is a cognitive involvement, we cannot do a proper assessment below 5 years of age, hence keep it as a different entity. When you can do a proper assessment after 5, then you stamp it as ID. So that cognitive element has to be there. There was a lot of debate on this before the IOP guidelines came up. I still remember a 4-hour meeting ending without final inference. The inference came later, where it was clearly mentioned that children whose delay in 2 or more domains, 2 or more domains, can be explained primarily by motor delay or severe hearing or visual. Agar ye hoga, then this will not be included in GDD. It clearly mentions these need to be excluded from the diagnostic label of GDD. So now from this IP consciences, this part is clear. Now, then we come to, then we have 2 words, GDD and ID. Particularly for the postgraduates, this is a confusion. One point is the age criteria. Another thing we need to remember that this is sort of a graded spectrum. While the term before 5 years is global developmental delay, mark the word delay. Whereas after 5 years we are saying intellectual disability. What delay has become disability. Why? Because in GDD, 2 or more domains are affected, true, but that affection is just that it is going below the expected level. A child who should be able to walk at 1.5 years, at 3 years is still not walking. That is a motor delay, but you have not said that the child will never walk. You cannot say that at 3 years. So up to 5 years, the milestones are delayed, but they may come to the acceptable normal level. And that is what happens. Generally in GDD, the common scenario that we face is that there is motor delay, there is cognitive delay, there is speech delay, and so on. By 5 years, the child overcomes the motor delay. The child learns to walk. Though late, he learns to walk. Though late, he learns to talk. But the intellectual disability persists. So after 5 years, when we see the child, we take a good history, delayed milestones were there, but he has caught up at the other levels. But the intellectual level has not been caught up. That is where the transition from GDD to ID comes. Now remember, do all GDD become ID? No. Many children who are stamped as GDD are not developing only because of poor psychosocial stimulation, inadequate early childhood development, improper nurturing care. So there, if we can give that stimulation, they will catch up. They will not land up in ID. This is one thing. Somewhere the diagnosis will have gone wrong. Somewhere the maturation may be late, but it is finally reached. These children will not go into ID. So the bottom line is all GDDs do not become ID. On the other hand, have all IDs come with a previous history of GDD? That is also not true. Most of them do. So all GDDs will not land up in ID and all individuals with ID maturation, poor development in the early years, they may catch up. They have the whole potential, only their environment is not adequate. In that case, what do? If we get this sort of a child where you're suspecting that the psychosocial environment is not adequate, give early stimulation as we will be seeing in the second half and reassess after 6 to 9 months if there is a catch-up. So you know what you're dealing with. From here we go on to the classification of GDD. Okay. Well, all I would mention here, these are known things. Initially or till recently we were classifying according to the developmental quotient. But the RPWD, that is the rights for persons with disability, they have clearly mentioned that it is the adaptive function. Because of a cognitive delay, the child cannot adapt to the environment. It is the adaptive function that is more important to be assessed to understand how the child will manage himself, handle himself. Hence, it is all now dependent on the social quotient. The figures remain the same. 55 to 70 is mild, 36 to 54 is moderate, 21 to 35 is severe, less than 20 is profound. But here what I want to focus on here is it is the SQ, not the D. From here, let us quickly go on to the etiology. Okay, we have a child with global developmental delay. We sort of try to streamline it. What are the causes? Biological, non-biological. Non-biological I have already discussed. These are the factors which come from the environment. Coming to the biological factors, environment I don't think I need to spell it out, it's all over there. Common ones, low socioeconomic status, poor socioeconomic, poor stimulation, etc. etc. Coming to the biological, as Dr. Costa was clearly mentioning, that perinatal history is very important. What happened around birth, that can lead to developmental delay, immature, improper brain development. On the other hand, there are some causes which are genetic or chromosomal. So this is a broad way of classifying. Perinatal causes you all know, I will not discuss the details, but they have to be looked into. Coming to the biological or genetic or chromosomal, here there is a clear-cut segregation of syndromic and non-syndromic. So in syndromic, the common ones are Fragile X, Rett's, and Angelman syndrome, cardiomyopathy, these are them. Then we come to the non-syndromic ones where there may be a gene mutation problem. It may be a CNV problem. So these are various other problems that are gradually being identified. It's a huge group. I will not go into any details because this will be taken up in a detailed manner later. In between comes in those conditions, neurodegenerative disorders, IEM, which have a genetic basis presented with a product. So these all come under the purview of genetics. This is a simple way of categorizing the etiology. Now, if we look at a disclaimer, this is not my data, this is taken directly from Nelson's. The reason I took it is we sort of tend to brush across these pages. And the importance of this are not the causes, you know the causes, I will not be reading them out. What I want to emphasize here is, again, going back to what Dr. Costa has mentioned, chromosomal causes are very, very important. The chromosomal disorders, starting from trisomy onwards, account for more than 20% according to Nelson. Indian data is a little different, I am not quoting them, but they go more or less pari passu with this. Then the other genetic syndromes, they are picking up, they are gradually increasing. That also counts for more than 20%. Every other day, some new mutations are being found out. And also, coming to the CNVs, there are identified CNVs, non-identified CNVs. With so many non-identified ones are becoming identified after a few years. So it's gradually increasing. Then the non-syndromic amount accounted for 10%. If we go down, IEM, neurodegenerative, familial, perinatal causes account for 4%. This is more than 10% in our country. This is where we need to put a little extra focus. After all this, 20% still remain unknown. Okay. So this much about GDD. Now, what are the other conditions that you need to be able to differentiate from TD. What are they? The differential diagnosis into two sectors. One is those which mimic ID, another group involve ID as an associated impairment. A neurodegenerative disorder with all systemic manifestations and seizures, etc., also have it. That is one. So keeping these two heads, when you are thinking about doing a DD, keep these two things in mind. With that, here we have a list of the common differentials, which include psychosocial deprivation to start with, severe hearing and vision loss, without any cognitive decline. For those of you, how many of you have read the novel, The Brute, I think by Oscar Wilde? Wrong? Anybody read it? Old age novel, a wonderful book. If you can set your hands on it, go through it. It's about solving mystery, a death, which nobody was being able to reach to. It was done by an individual who was coined as Brute. In older days, a person who's mute, deaf and blind, cannot communicate, and arrogant and very rough. So everybody knew him as the Brute. He's the one who solved the mystery with his strength, and he had perfect analytical power. So cognition was fine, everything was fine. He appeared to be a Brute. So this is what we mean by severe hearing and visual impairment as a differential diagnosis. There are also mood disorders, attention deficits, ASD, autonomic, cerebral palsy, of course. Then we come to the other aspect, comorbidities. There may be medical comorbidities, neurological, non-neurological. There may be behavioral comorbidities, which include ADHD, ASD. Now, these comorbidities are ones which can coexist. So remember, the same disease, ASD, I am mentioning as a differential diagnosis, I am also mentioning as a comorbidity. So when you are thinking about GDD, make sure it is GDD and not something else totally. Also make sure whether it is DDD along with these other things. So it takes a lot of thinking in it. It's not just putting on a stamp. Okay, with this background, approach will be taken up in details by Dr. Sharmila, but I'm just trying to give you a brief entry into the issue. So when will you start suspecting? It differs according to age. In a newborn, a dysmorphic newborn, a microcephalic one, a big head, these are suspicions. A little older, early infancy, 2 to 4 months, what happens? Baby fails to interact with the immediate surrounding, not looking at the mother when mother is feeding. This is one common question we ask. This may be a sort of lead. Are we dealing with a child who will learn to deal? Later infancy, gross motor and language delay. In toddlers, language delay becomes more prominent, difficulty in following simple instructions. Preschool, it is an educational aspect that will come into focus. Now, with this, how you know when to suspect GDD? So when you are suspecting GDD, how will you proceed? What are the things you need to look in? First of all, rule out other differentials. We've talked about differential diagnosis. Number 2, identify comorbidities. We've already talked about that. Assess the level of development. Now, having done that, there is DD. What is the level of development? Here comes in the importance of doing a developmental screening and developmental assessment. Finally, identify the etiology. We already know what the probable etiologies are. For that, we have to do an identification. Keeping these 4 things in mind, we are approached with progress. Screening, I am not going into details, but remember, the earlier you screen, the earlier you, even if you can go at a pre-symptomatic level, then you can prevent GDD from developing. That is a major notion. We need to look at prevention. Once it's totally informed, it becomes more difficult to manage. So how can you do it? You can do prenatal screening, you can do neonatal screening, a routine developmental screening. All these will help in seeking out those who may go in for GDD. And don't forget to screen for autism. ASD screening with a simple MCHAT at 18 months is going to help you a lot. And this is something every single practitioner can do. It does not take a lot of time. It's a very simple tool, freely downloadable, easy to administer. Try it out. It's going to work. Okay, there are lots of training tools. I'm not going to mention them. You know which are available. You can get RPSK training tool now on the DIC and the TDSC. Make yourself acquainted with it. Start working with it. Then, coming to the clinical approach. In history, remember the perinatal history, the pattern of development, whether there is regression or not, family history, consanguinity, history of miscarriage, all of these you must answer. Then, a head-to-foot examination becomes very important. Most of the diagnosis happens with your head-to-foot examination. What to look for is for you to think. Make a chart. I will be showing you a chart in the next slide, but it's not to memorize, it's just to know where you need to put your focus and what all changes can happen. Do not forget anthropometry, because those syndromic children mostly come with short stature or some other problem there at the growth level. There may be associated malnutrition, a very common accompaniment. So, anthropometry is important. Developmental assessment, yes. Having done this training, now we should go for a median assessment and neurological assessment. These are the different avenues of clinical examination. What I find, the theory part, particularly for the postgraduates, they know the theoretical thing. Whatever I have discussed, they know much more details of this. But when a child comes, they start suspect at the right moment, no problem there. Then they come up with the child, ma'am, now what? And you can see the blankness in the face. I wouldn't blame them. The fact is, where to start and where to end. How much to do with these children? That becomes the major issue. So if this format is clear in our brain, then we need to take a history. We need to do a head-to-foot examination, an anthropometric, developmental assessment, and neurological assessment. Then you will not miss anything. So these are the common dysmorphisms. It can affect, at the right side, I will not read out. It can have an impact on the stature of the child, the head, the neck, the hair, face, eyes, ears, all of them are informative. Nose, nipples, how the nipples will help us? White space nipple, internal symbol. So simple things like that. Hand,
down.
what else? Anything in the fingers? Okay. So keep thinking. There are so many. There's no end to it. And of course, think. Coming to investigations. I will not talk about the investigations, but I'll just talk about a few do's and don'ts. First things, investigations should follow a detailed clinical examination, the ones that I had mentioned. Don't jump for investigations. Primary intent, now there are so many things that can be done. Don't just write down a backing of crisis. If we do want to investigate, we will investigate for those which are treatable. You are thinking of a very rare syndrome, you do a genetic study that appeases your academic appetite, but the patient's pocket is totally, it's a big hole. That will not do. What am I going to do by knowing this syndrome if I don't have a treatment for it? More important is to diagnose those which are definitely treatable. Like peaking, your vitamin deficiency, some things like iron and vitamin B12 deficiency, and a few like that can be done easily. Do differentials and mimics. So do a visual test, do a hearing test, ESG screen. These are more important. Identify other possible causes and take their part later. Do not order all tests routinely unless indicated. This is the bottom line of the message that I want to put forth right now. Then the detail will come in the later presentations. Coming to specific tests regarding neuroimaging, MRI, when to do an MRI. Not every child with GDD needs an MRI. This should be clear in our minds. Abnormal insights, seizures, or other neurological features. Yes, we need a neuroimaging. MRI, especially if we're thinking about carnitine deficiency, we're thinking about mitochondrial disorder. need to do it. EEG, if there are seizures or an epileptic syndrome, definitely have to do it. Biochemical and metabolic, again, if there is some indication, some clinical indicator towards those diagnoses, definitely do it. Evaluate where can it be treatable? Thyroid. Again, B12, iron deficiency, vitamin deficiency, the levels, these may become important. Most of it. Genetics tests, again, I will not go into the details because speakers after me will be coming and detailing on this. Before I end, again, a very quick algorithm as to what we will do to summarize what I have mentioned over the last few minutes. If DQ is less than 70 in 2 or more groups, then we take a detailed history and examination. Hearing and vision testing is mandatory. Screen for comorbidities. Investigations should be based on clinical judgment. How? Investigate for treatable causes. You know what they are by now. What are these treatable causes that we must look for? Thyroid. Okay. Then abnormal health size, neurological findings, seizures, go for EEG and MRI. Consanguinity, family history of diagnostic history of DDD. Then we go for a metabolic screen for IEM specifically. Nuclear etiology, genetic causes suspected, definitely go for genetic study. Study has a lot of importance here, but we won't jump for the genetic study every single time. We cannot afford to do it. So with this I end. Thank you.
Thank you, Nandini, for that excellent talk. I will invite Professor Shravan for
How many of you like crime stories, books, detective stories? Who's the famous Bengali detective? Hello, are you guys awake? Hello? Bomb detective is equal to? Okay. Sorry? Yomkesh Bakshi? Okay. So I have on purpose not put the bomb detective here. Can somebody on the left hand side tell me if the left photograph, you guys may or may not know him. Okay. So CID, ring any bells? Right hand side?
Sherlock.
Wow. First person who named Watson first and Sherlock Holmes second. Great. So why am I putting this? Because it's like a detective story. It's fun. How many of you think it's fun? How many of you think, oh God, final exam में तो fail हो जाऊंगी because देखो DVD मिल गया? Is that the usual reaction? I want to make it fun for you guys.
What is some but highly scoring?
So sorry?
What is some but highly scoring?
Yes. Again, another thing. For the students, if you get a case, a neurological case which is difficult, and I'm sure sir will also bear with me, you will never fail. You can get bad marks, but you will never fail for for not being able to do well in a difficult case. So that is a simple idea. Okay, so what I wanted to focus upon here is clinical approach. Now, since we have majority of students and we have a few practitioners, I just want to tell you that I have made this slide, this presentation for a clinical approach in the OPD. This is not for the exam. no pieces missing. How do you start? From the ends, okay. Sir, navy blue shirt. How do you start from the, yours is light blue. Sir is navy blue, yeah. How do you start the jigsaw puzzle? You look for which pieces? You look for the corner pieces, right? Thank you, thank you. One corner here, one corner here, one corner here, one corner here, right? Because there are only 4 pieces that have corners. You cannot put a middle piece, you can't mistake a middle piece for a corner. Then you put a little, you find, okay, this is the face, you make a face. You find a dog, and you make little pieces. So the same thing goes over here. You have to look for the clues, put the clues and name the little piece out and you find the picture. So what have we covered so far? What have we done? The definition. So, ma'am, can you tell us the definition? You can be wrong. You can, yeah, you. It's okay, ratta nahi lagana hai. I just want you to know what do you, okay, my question is what do you understand by global developmental delay?
Delay in more than two or more milestones.
Perfect. Sir, green, dark green, bottle green. Check. Name the developmental domains. Wonderful. Gross motor, fine motor, social language, and last cognitive. Great. Last, navy blue. For global developmental delay, and we just covered 2 or more domains. Gross motor and fine motor clubbed together. So gross motor, fine motor, motor. Okay. What is cognitive domain?
Intellectual.
Okay, thank you. And before I come back to this, what age group are we covering? Till 5. Okay. So if I ask sir, what is the capital of India? Which is cognitive? It's cognitive, right? So if I ask a child, a 4-year-old or 5-year-old, what is red? Say identify this color. Red or maroon or whatever. Cognitive. If I ask, how can I test the cognition of a 9-monther? Can I ask him colors? Can I ask him ABC? Can I ask him the capital of India? So, how do I test cognition? Recognition of mother's face. So, recognition of mother's face, I see. Vision. Hearing, because he's heard the question. And social interaction, he knows it's my mom. So, it's an interaction, it's an overlap of various things. So, all these domains are basically man-made artificial constructs. If you are understanding something, if I am reading something, it's my vision, it's my cognition, everything, it's my receptive language. So all, if I say gross motor, fine motor, these are all artificial constructs made for easy understanding, but they all overlap. So, Amoshni, will you do me a favor, just keep on telling me the time because I tend to go a little overload. So we have done, right now what we will do over here, these are the steps. So what is the first step? What is the first point when a patient comes to you in the OPD? Why have they come to you? Because the parents have some concern regarding development and they think you can answer or you can sort out their concerns. Yes? Okay. So what is the first question? Is it actually developmental delay? So what are you going to do as a practitioner or as a student? You're going to first check. So if suppose somebody comes and says, "हाँ मेरे बच्चे को बुखार है," what is the first thing that we do? We take the temperature. You first see and you ask him in the history, how many days have you been taking the temperature at home, etc., etc. So you just want to know, especially peak summers when it's really hot, it could be just environmental hypothermia, right? So here we take the current milestones in all the domains. And with our basic understanding, with our basic knowledge that we have learned in the 4th semester of undergrad, that this developmental milestone number, this age, and this milestone comes at this age, you can make up, okay, yes, this seems to be a little off, right? The second is unrealistic expectations, especially in nuclear families, hyper parents. They feel that, oh, XYZ kid is doing this, he's a 10-monther, he's saying Baba, Dada, etc. My kid is not saying anything. So they get worried, peer pressure, what the Jones is doing. So first of all, is the expectation realistic or not? It's not like Cinderella, 12 o'clock suddenly the pumpkin, the porch turns into a pumpkin. Not like that. There is always a kind of a lag period. The third is an infant who is born preterm. Ma'am will know, Dr. Chandra will know, so many babies are born preterm, so many babies while they're in the NICU, they understand, yes, it's my baby was preterm, my baby had problems. But the moment they go there, discharged, the parents tend to forget. Then by the time the child is say 8 months or 10 months or 15 months or 18 months, it's a very remote memory that has subconsciously been suppressed. And they forget. And they say, oh, that kid is 18 months. My baby who was actually born around say 12 weeks before time is still not. And they don't remember that yes, ma'am told us that your child will always kind of minus so many months. They forget it by the second year. So that is when the uncorrected chronological age is not being used. And sometimes the pediatrician also forgets to ask whether the child was born preterm or not. So they forget to minus those very crucial months and exclude causes that can mimic GDD, which Pam just talked about. So I'm not going to go into that. So after your initial evaluation, which will take you probably around 10 minutes, yes, there is some developmental issue in this child which needs an evaluation. So now the second thing, ma'am talked about patterns. Is there any specific patterns? So yes, this is what we're looking for. Is a predominantly motor delay? Is a predominantly speech and language delay? Is it global developmental delay? How do we see that? Again, we just talk about these are all the preliminary evaluations that we are doing. So the presenting complaint will give you a clue. If suppose the parent says that my child cannot walk, okay, it can be in predominantly motor delay, it can also be in global developmental delay. If the parent says my child cannot walk and his arms are very stiff when I press and undress him, I have a problem. So which category will you fall in? Spasticity. So it's probably predominantly motor delay. So again another 2 minutes, you arrive at that. If you have a parent who says my child cannot hear, my child is okay but he doesn't speak, which category will you fall into? Predominantly speech delay. So the pattern of what the parental concerns are giving you will also give you a rough idea. Okay, it's like when a child comes walking in respiratory distress. Do you start taking the history and everything immediately? No. In the OPD, you will look at the distress. You will auscultate Beezer, not Beezer. Beezer, Sikha, nebulization, maybe it's a bronchiolitis or a bronchial asthma or a wall ride, depending upon the age. Remember what ma'am said? Presenting complaints and the age coupled together. Because a 1 month you're not going to think of bronchial asthma Beezer. But 1 month you will think of bronchiolitis. Similarly at 10 years old you're not going to think of bronchiolitis, you're going to think of bronchial asthma. The third thing is the cursory examination and discovery that the observation in the examination, the child walks in the OPD. When do you decide, okay, pick up first year, chalo, le chalo, isko emergency में ले जाओ. या अच्छा ठीक है, chronic case है, आराम से देख सकते हैं. That is your triaging. The same way you use that cursory observation and examination when the child has entered from your door. By the time he has reached your table, you have made a certain assessment, and then you have the milestones. So the presenting complaints for GDD, as ma'am has said, will be purely cognitive. Again, cognitive. Remember, it has to be age related. So delayed acquisition of milestones compared to the peers, age inappropriate understanding. So for a 8-monther, if I say Otaki, so the child will look in that direction. Whereas if it's a 2-year-old, if I say Otaki, he may give a response. And if it's a 5-year-old Otaki, Ota fridge, etar moddhe thanda jol thake. Okay, so depending upon the age, the cognition will differ. The understanding and following instructions will also differ. Age inappropriate syndrome walks in, will you be able to? No. So there are certain things that you can identify, there are certain things that you can't identify. So here I am looking at the first impression, any indicator of the neurophysiology that you know. If a child with, say, mucopolysaccharidosis comes in, a short child, very short child, or some kind of spinal dysraphism or something, that you'll be able to see. Or if you have a huge hydrocephalus or a meningomyelocele, these are things that you can identify with the first impression. Any apparent dysmorphism, a child with cerebral palsy, an 8-year-old neglected, spastic quadriplegic child with contractions, he comes in, you'll be able to make a diagnosis. Any evidence of hypotonia, a floppy child, you'll be able to at least appreciate that. Neurocutaneous markers, tuberous sclerosis, you have the stigmata, you'll be able to pick it up. So again, first impression. The second column on that side is what you're observing while you're talking to the parents. What is the child's verbal, non-verbal response, social interaction, how is he behaving with his parents, with the siblings around, what's his behavior like, and the extent of the parental support required while he is navigating your OPD sitting over there. Again, these are all things that people imbibe. Developmental history. All of you know the developmental history. You know that there are certain milestones that are asked about in each of the domains that we just talked about. So here, when we talk about DDD, we've talked about developmental closure, we've talked about developmental age. Who does psychometric testing? A clinical psychologist or a developmental pediatrician or a pediatric neurologist. So are you going to do a developmental psychometric testing there in the OPD? No. So how will you say that there are 2 or more domains that are affected? Based on your clinical bedside knowledge, 4th semester undergrad developmental milestones. Mota, we're looking for the developmental age. We're not looking to say that DQ is 85.2. We're looking at the profile. Basal, non-basal. Diarrhea, is diarrhea acute, is diarrhea persistent, is diarrhea chronic diarrhea. This is all you know, you have the basic knowledge, the same base. What is the last milestone that the child got? So like for instance, a gross motor, he can walk. So we all know kids usually start walking by 12 to 15 and he still can't run. We also know running comes usually by 18 to 24. So that means his gross motor age will lie somewhere in between. The same way for fine motor, for social, for language. Language is vocalized and we know it comes by around 4 months. No monosyllables, we know that monosyllables should come at 5 to 6 months. So if it's not come in between. So if I say a child has passed class 3 and is still not in class 5, that means which class is he in? Class 4. So it's the same kind of logic. So we'll look at the pattern. So okay, gross motor में इतना है, fine motor में इतना है, social में इतना है, language में इतना है. 2 domains हैं, gross motor, fine motor and language. So 2 domains and more, right? So here we've got the domains. So these are the patterns. Predominantly motor, you can see here gross motor, fine motor is, there's a difference between the social and language. And in predominantly speech and language, the language is more of a middle thing. In GDD, there are 2 patterns. One is in which all 4 domains are kind of evenly delayed. And the other in which you may have a slight dissociation between the domains. Again, not 82.6, 67.4, 33.4. No, it's the profile of the developmental age that you have ascertained from your working knowledge of developmental milestones. And always consider it to be significant if there's a functional impairment in the quality of life. So in the quality of life, usually for a young kid, a 4-year-old or a 5-year-old, what will it be? It means the activities of daily living. If the child is unable to perform activities of daily living which other kids of the same age can do, due to this delay, then that means there is clinical significance. Right? You're with me so far? Yeah. So, step 6, now we're looking for the landscape. We're trying to look for the comorbidities also. We have to be painting the picture, remember? So, in that picture, what ma'am talked about, neurological comorbidities are usually very common. Epilepsy, tone abnormalities, difficulty in swallowing and chewing, sensory impairments, hearing, vision, medical issues that are common, sleep, constipation, GRD, recurrent respiratory illnesses, known dysmorphism, behavioral psychiatric illnesses. So by now, you have this first draft in your head. You have GDD, Intervention is a must. Etiology is also a must, but intervention is a higher must. So now we are looking for more clues. We are expanding. We are looking now. First of all, is okay. We had a road traffic accident. I know it's a red car. Now I know it's a red car and it is a Mercedes. Now I know it's a red car. It's a Mercedes in which the license plate is. What's your license plate over here? Kolkata का क्या है? WB what? Any whatever. WB0101 whatever. And if it's a DL, I know it's a Delhi की car. So that's giving you direction. So now we're looking for significant past history, antenatal, neonatal, natal history, family history, third generation pedigree tree. Look for risk factors, genetic, biological, environmental, social, and never ever forget about immunization and dietary. What happens often is that you'll have a child coming to the center, epilepsy clinics, neuro clinics, who've come at least 12 times in the entire year and still has been unimmunized. Because the focus of the parents is epilepsy, the focus of the clinician is epilepsy, and basic pediatric services take a backseat. So you must remember that that is very important. Examination, as ma'am has talked about, anthropometry, general physical examination, dysmorphic evaluation, an extended neurological examination. For the PGs, what is an extended neurological examination? Can you tell me? It's just fancy name for neurological examination जो अपना standard है with a developmental assessment. So clinical developmental assessment and neurological examination and a bedside evaluation of the vision and hearing is an extended neurological examination, and obviously the systemic examination. So we're digging deeper and deeper. So whatever clue you get on your examination history, you go back to the history. You go back to the history. You go back to the examination. You look for further. The way you do any other clinical evaluation. Sure. Yeah. 3 minutes. So now the next step. We're expanding the clinical phenotype further. Now we're planning the investigations. We're planning the referrals. So investigations is not investigations for etiology. Investigations is for broadening, making the picture clearer. So now you're bringing a magnifying glass. So for ophthalmological evaluation, you're looking for colloidal anomalies, the visual activities, twin, DEP if necessary, direct or indirect ophthalmoscopy, extraocular movements, depending upon what you feel you can assess clinically, and then you refer to your expert. For hearing, you have the test, nutritional, EEG, GERD, and referral psychometric assessment. Now again, the psychometric assessment here is not for your etiology. The psychometric assessment here is for what? What's it for? Why is it important?
Assessment of degree of disability.
How will that help? You're right, sir. How will that help?
Intervention.
Exactly. Intervention. Absolutely. Great. Because we want to know what is the child's strengths, what is the child's weaknesses, so that we can use the child's strengths to build up his weaknesses and plan his what we call IEP, individualized educational plan, or basically his intervention plan. So that is why we are getting the psychometric assessment done, and it is also confirming your findings, but it does not have much bearing on getting to the etiology, right? So now in this case wise, so far what have we done? I'm just coming to that using a case. So this is a 9-month-old Muslim boy who presented with delayed acquisition of milestones. Noted since a few months, they couldn't say exactly how much many was it, and progressively increasing head size noticed since the child was around 6 months old. So he has the present illness is that the parents noticed that he was attaining milestones later than others, and that his responses and interest in the surroundings and people around him was a little less. And there was no apparent motor, visual or hearing impairment. According to the parents, he was a 9-month, it started a little bit of pureed food, so the swallowing was okay since the beginning, and he hadn't really started chewing because he hadn't been given stuff that was chewable. They had not perceived any tightness or looseness of the bodies or limbs during activities of daily living. They had noticed that the child's head size was increasing since around 6 months of age. There was no history of any prolonged fever, no vomiting, seizures, head banging, excessive irritability, excessive sleepiness or lethargy or loss of consciousness. There was no past history of hospitalization for prolonged febrile illness, trauma, seizures, loss of consciousness, sudden onset of weakness of limbs. So with that background, they also went into the antenatal natal. So it was a booked immunized pregnancy, uneventful, quickening was at 20 weeks, breathing movements were okay. The ultrasounds done in all the trimesters were fine, but mother had received the supplements. It was a term, normal vaginal delivery am I looking for heart rate and the blood pressure over here? Yes. So it's a very indicator for increase in intracranial pressure. That was normal. The head circumference was, although it appeared to be large and it was the complaint, it was +2 Z-score. The weight for age was 0.69, the length was okay, weight and length was fine. So now look at this child. Appears big. Does the head appear big? So the mother's concern was fine. Okay, ठीक the Z-score was 2.0, but does seem to be unusual, yes or no?
Yes.
Okay. So we're not going to wait for him to hit 3Z. कि अच्छा कर जा, एक साल बाद आता है. No. We have to, yes, there is a problem, there is development, and yes, the head seems to be something different. There's a large head, the AF appeared large, the AF was 3 into 3 centimeters open level, the PF was closed, which is diffuse, broad forehead, normal occiput, no dilated veins over the scalp or any cranial bruit, sparse hair on the scalp, fundus and retina was normal, the spine and the skeletal system was normal, and no overgrowth of any other body part. Why? So you can have certain syndromes in which it's not just the head, it's like whether it's proportionally big, Sotos, Beavers, or Proteus, you can have that. Okay? So again, now this is the semilateral, the child was immunized, had obesity scar. There was no pallor, no jaundice, no lymphadenopathy, no rickets, no hemolytic facies, no neurocutaneous stigmata, no rashes, petechiae, ecchymosis, keratosis, cataract. Cranial, the central nervous examination, he was conscious, alert, interacting with parents and examiner, no cranial or focal neurological deficit. There was slight generalized hypertonia, wasn't floppy, normal spontaneous movements, power was okay, reflexes were normal, the parachute reflex had come, no neonatal reflexes were not persisting, plantar reflexes were bilateral extensor, normal or abnormal? So, 8 month, 9 month, normal. So, we don't, oh God, bilateral extensor, no. Fine. No signs indicative of increased intracranial tension. We did a developmental assessment by a 180-degree flip, which was kind of again by the maneuvers coming to roughly around 5 to 6 months, 5-ish months, and the fine motor. All this developmental assessment is bedside clinical examination, just to confirm whether the developmental milestones that has been elicited is on spot or not, and it kind of matched what the history had elicited. The auditory assessment, visual assessment again was fine. But please remember, any child with global developmental delay, a visual and hearing assessment, even if you've done it bedside, you have to do a formal one. It has to be done. You can't rely on your bedside, because bedside clinical evaluation of both these sensory parameters is not very good in terms of sensitivity and specificity. The other clinical examination was normal. The general, the psychometric assessment revealed that the DQ was 51.1, moderate delay. The formal visual assessment was normal, as well as the hearing assessment. And if you look at the various domains, physical and self-help was 4 months, social was 3 months, academic, cognitive was 6 months, communication was 6 months. And chronological age was 9 months. So now we look at the clinical synthesis. Clinical synthesis is summarizing everything to see whether you can go at a direction. Can you make a differential diagnosis or not? So over here we had global developmental delay. Neurologically there was mild hypertonia, there was no focal neurological deficit, there was no increase in cranial tension or sensory impairment. There was macrocrania, onset in the first 6 months, not fetal, probably infantile onset. There was no visceromegaly, there was no pallor, never had been transfused, there was no hemolytic disease, there was a previous abortion. So whether the child had no significant antenatal, perinatal or family history, no hospitalization for any chronic illness or fever. So what would you keep now as a differential diagnosis? Anything? Something, anything comes to mind? Sorry? Hypothyroidism, okay. Okay, so one hypothyroidism, there was no post facies. Rickets, okay, so rickets. Okay. So coming back to what Ma'am had said, we have to look for the investigations, we have to plan, looking for the nature of the injury, nature of the insult. What is the nature? Nature is genetic or acquired. Okay? Mota, genetic, acquired, and the timing means, do you think line which is pointing you to a direction, then a second line which is taking your journey a little forward, and the third line is which arrives at your destination. You all get that? But an important ma'am said it has to be indicated, it has to be rational, it has to be evidence-based, it has to have an ecological need. So suppose I say we are going to take X test which costs 50,000 bucks and which can pick up one child out of a million children. And you have another test which says, which costs 500 rupees, which can give you an idea maybe about say 75% of kids. So will you take this one or take this one? So you have to take an educated decision, and remember we are all working in, whether it's in Kalyani, whether it's in Kolkata, whether it's in Delhi, in a government setup, or whether it's some other people who have come from other places. We have limited finances for parents, for hospitals, for resources. So we have to use that setting. So now there are various approaches. So when you have a situation in which you don't know what you're dealing with yet, you've taken in history, you've done the examination, you've done a couple of tests, you still don't know what you are dealing with. This is an empiric approach. There are certain international guidelines which we cannot use in our setting. Why? Because they are tuned for the high income countries where you don't have common causes which are seen very highly prevalent in our setup. Perinatal asphyxia, neonatal hyper, bill which requires double volume exchange transfusion, goes into connectors, infections, trauma, congenital infections, that is not there. So they totally disregard it. Then they assume that all kids have undergone neonatal screening for all the INs. We don't have that. Then they also assume that their family tree, if there is somebody who has some issue has been worked out, that is also not the case here. So, and also they have genetic and metabolic tests that are easily available. So what I have done is a compilation and approach which is based on these guidelines plus the last 20 years of my own experience. So I'll just read you through this. Probably 5 minutes motion, is that okay? So we've done this parental concern, history examination, comorbid condition synthesis. So we've come to the global development today. We've ensured this functional impairment in multiple settings at ADLs. We've ruled out micrometers. We've done the psychometric evaluation. We've excluded all the unrealistic expectations, etc., which is on the right hand side. So any kid with predominant motor delay, CP, speech delay, ASD, progressive encephalopathies, abuse, etc. are all out. We've critically reviewed whatever evidence we have of the neonatal insult. Always go at the documents. Don't say, okay, neonatal APGAR score, birth asphyxia, and then you look at the reports and you see that the APGAR score is 8, 9, 10. So always see yourself, do your critical appraisal yourself. TFT, somebody said hypothyroidism. Look at the causes of DVT that can be, rectified. So, and you have subclinical hypothyroidism also. Do a TFT, review indications for lesbian if required. Look for dysmorphism. Is it clearly dysmorphic, possibly dysmorphic, not dysmorphic? If he's clearly dysmorphic and it's only isolated, microcephaly or length of weight, look for congenital infections, test accordingly. If it's a recognizable gestalt, order the specific test. If it's not, consult a geneticist or expert, do your own literature search. If it's possibly dysmorphic or dysmorphic, always look for concealed anomalies. So you do a clinical examination, get an ultrasound abdomen, review for an echocardiography, review for an MRI CT. The third is if the child is not dysmorphic. Is not dysmorphic and you have a definite suspected diagnosis, you apply the clinical diagnostic criteria if available, order the confirmatory tests, or start with supportive tests and then go to the confirmatory test. If there is still no diagnosis in mind, review for neurological indicators. Now we are looking for the role of neuroimaging. Neuroimaging, around 30 to 70% of children with a GDD will have some sort of vague abnormality, which does not give you any direction towards etiology. So the etiological yield per se of a neuroimaging is 10 to 40%. If the child has epilepsy, focal neurological deficits, macrocephaly, or non-familial macrocephaly, pyramidal, extrapyramidal signs, you go ahead with the neuroimaging, MRI more than CT, and if the neurological indicators are normal, so the kid is not dysmorphic, the kid does not have neurological indicators, now that means it can either be genetic or it can be metabolic. Now the metabolic yield is only 1.5% of metabolic causes on later. So coming back to our child, we have this we talked about. So we don't know whether it's acquired or genetic. What is, out of all these, what is the best clue that we have in this child? What is the best handle? Out of all these things listed there, what is the clue which you will pick up? Macrocrania, wonderful. So macrocrania, graduates, postgraduates. So that means possibly dysmorphic. So what are the components of the skull? Brain, these are finding responsive, thiamine does not have any adverse effect, primer. Okay, so we went ahead and we gave him thiamine. So we did counseling. Now going back to counseling management, not as a patient general, what is for the parents at this stage, what is the disease, why is it occurring, what is the clinical cause, complications, prognosis, reproductive implications, specific management, general management, comorbid conditions, multidisciplinary intervention, routine pediatric care, how to support the family, follow-up, anticipated guidance is what needs to be done for any kid. For this child, we started on specific dietary therapy. We started him on high-dose thiamine. We did all the things that I just talked about, monitoring the compliance with the diet and the thiamine, monitoring the biochemical profile, growth monitoring and the developmental profile. And at 18 months, we saw that if you see the trajectory of the head circumference was almost static. It had not increased any further. The biochemical derangement had decreased. There was no episodic decompensation and the DQ had also improved. So the parents were happy, we were also happy, but we still don't know whether we were right or wrong. And this is the usual kahani that happens in our resource limited things. But you've got to try. You have to keep on working at it. And this sounds very easy, but it was like almost around 3 months of intense study and dimag kharab karna. Okay? And you have to get the parents on board at every time. If you say that you don't know, you tell them that you don't know. But this is what we're going to plan. So the key messages are comprehensive clinical evaluation, direct and investigative approach. Send the child for early intervention as soon as you decide that the child has developmental delay. Plan individualized testing, which has to be sequential, rational, evidence-based. Keep the parents in loop whether you know what the diagnosis is or whether you are not. Do pre and post-test counseling. Etiology is a certain majority. It depends on the expertise of the person who is evaluating. Involve them. If it's inconclusive, keep under follow-up because often the picture changes. Management should be multidimensional, and thank you so much and sorry for exceeding my time. That's it.
Because all those protocols which are mentioned in books, time protocols and all, we cannot apply them and they should not be applied. Because clinics, number one, number two, is what we learn. And clinics includes a very good history table and post clinical examination. Of course, how to take a good family history. How many of you all know how to make a pedigree chart? Students, you have to face the exam. You don't have to. So, what are the symbols which stand for what? How do we know consanguinity? How do we know defected? And then how do we make it? So, and what is consanguinity? First degree, second degree, third degree. So that also will be part of the workshop. So, now I will request Professor Shuchokra Mukherjee to enlighten them on the specific aspect of global development. Lot of people come and push us to do these tests. Please do this from our lab, this, exam, clinical thing, the whole thing, exam, what even the whole chain of how is coming in. So we must actually not forget the character. It's a very important thing, and that we will see. So Professor Shuchokra.
Good morning and welcome to Department of Neuropedicon SSKM. I'm very thankful to Madam Dr. Namita Chatterjee and Sharmila Madam for giving the stepwise approach, because this global developmental delay is like a package thing. Whenever I have seen the prescriptions or from our OPDs also somewhere, so developmental delay means first of all there will be thyroid function test, then some potential IPGMER, EEG, MRI then, and lastly now it has been added the clinical exome sequencing. So one of my nursing staff, it's not related to global developmental delay, related to some intermittent fever. So the child age was 11 years and the baby, the child was having irregular fever for some few months. When the pediatrician was investigating, so when the pediatrician was investigating, he has written some tests. And my nursing colleague came to me last week, madam, all the tests will cost 40,000 rupees. So 40,000 rupees for fever. This being the prescription, and it has been written that rheumatological screening because it is irregular, undiagnosed fever without focus, and there is some antibody profile, and lastly clinical exome sequencing, and all inclusive was around 40,000. So same thing occurs in developmental delay. When I was in just passing out, I joined in a private hospital. And I saw Dr. Mukherjee was there, Dr. Shapan Mukhopadhyay. I have seen how he could interpret the EEG. That was we were never thought about this EEG, this stepwise approach of this global developmental delay in our postgraduate days. So EEG was like a Hebrew or Latin thing to us, some waves, pattern or all. But now we were very lucky that some kind of this workshop or in the clinical bedside teaching, you are all acquainted the basics of EEG and some basics of the neonatal EEG. Okay, then we are going to the approach to genetic and genetic approach from a non-geneticist, from a pediatrician. So this global developmental delay, all madam has told this stepwise approach, and you have to have a standardized test and preferably the Indian scale by which we can at least compare our baby's performance with the peer group. So this is the global developmental delay, and if the scores is less than 2 standard deviation, that means 70 in the C or belly. So causes, I am not repeating, it's exogenous, genetic, non-metabolic and metabolic. So metabolic we have seen in the last case report on NSUT, how interesting it is, and actually it is a spectral disorder because we have seen isovaleric acidemia is also a spectral disorder. Micromolecular disease we always think that will present is a severe uncontrolled refractory seizure with high ammonia, refractory hypoglycemia. That is the classical presentation, but it's not like that. Sometimes the children presenting in later half of infancy, late childhood with cognitive decline, some problem in the balancing, in its hairstyles. So these are very subtle things. If you do not do a thorough clinical examination, you will miss. We have a baby on isovaleric acidemia. So that is a classical presentation, the second order baby. The baby came to us from Barashat within I think 7 days of life, classically presented. So we did TMS, it was diagnosed as isovaleric acidemia, but retrospectively when I took history from the mother, she said that the child is now 3 years old on special diet, because earlier that previous born child had died at 2 years of age due to aplastic anemia. It was written as aplastic anemia. Then we all went through the history and details. That baby had episodes of vomiting in the neonatal period that was missed and erroneously diagnosed as surgical abdomen. It was not, but that was also, that child had died due to isovaleric acidemia, presented non-classically at the age of 2 years with bone marrow depression. So this is the spectral disorder. Always think definitely the classical presentation may not be 100%. So always open your mind at the madam's case. So only macropenia, mild developmental delay, mild hypotonia, there is a clue for metabolic diagnosis. So what is the role of genetics? Why we are doing so many genetic tests? We as a pediatrician, what are the basic things we have to know how genetic tests will help us? Definitely for a diagnosis. If the baby is having a global developmental delay, there is nothing in the clinical presentation. So we have to know the diagnosis, whether it is metabolic, whether it is a CNS malformation, whether it is genetic, non-syndromic, And how the genetic diagnosis will help us? Prognosis definitely very good, and for future pregnancy, if there is any chance of recurrences in the subsequent pregnancy, and for a targeted treatment. So if you can isolate a cause of refractory seizure, then we can apply a therapy which is made for the particular disorder. So sometimes genetic test helps in not only diagnosis but for therapy also, for treatment and for next pregnancy counseling. So approach to GDD, history and clinical examination, clinical evaluation. It is 1/3 cases you can be able to diagnose by history and clinical examination. History means also the family history. Clinical evaluation from diagnosis in another 1/3 of cases, and only investigation is 1/3. So it is stepwise approach. So if you can do good clinical examination, neurological examination, basic diagnostics and investigation, most cases you will be able to diagnose of global developmental delay. So family history, prenatal, red flag sign for IEM, that is recurrent vomiting, ataxia, seizure, coma, movement disorder, it is very important. Sometimes in case of newborn also we are getting abnormal movement. We know these twins, babies twins, they are monochorionic twins. Newborn period they present with co-stimulus movement, and the baby were lost in follow-up. Now last week they presented with the global developmental delay, strabismus, nystagmus, and again this tremulous movement, but it is not severe as that was present in neonatal period. Now we are trying to diagnose both the babies are affected. Mother had some history of neurological disease but not genetic. It was acquired condition. But in that cases it is genetic condition, abnormal movement, global developmental delay and abnormal eye sign. So clinically it is genetic, and we have sent for TMS also, but again a problem. It is not a very affordable parent, so we are just doing a stepwise approach. So physical examination for global developmental delay is very important, and now we are coming to our topic is the genetic. How do we approach this the genetic test? So this is again from our Indian population, and it was published in the Journal of Pediatrics by Madam Dr. Monica Juneja. So detailed history again. If you were seeing any this algorithm, either Indian or from abroad, either Canadian Pediatric Society or US guideline or UK guideline, all the guidelines will start from a clinical examination and neurological examination. Either it is genetic diagnosis, metabolic, everything. So, what are the genetic tests? What are the genetic tests? What are the basic genetic tests? Karyotyping, very good. Any other cytogenetics where you can diagnose some specific disorder? Very good. Microarray. And the next step is not conclusive in the basic genetic test, then blanketly we are going for sequencing, clinical exome sequencing, and sometimes whole exome sequencing. So these are the reserve tests. Always try to correlate clinical findings with the basic genetic diagnosis. Otherwise, if the baby presenting with global developmental delay and the baby is not dysmorphic, not Down syndrome, that doesn't mean you will get clue from the clinical exome sequencing. You have to go from very basics. And for us, the pediatrician, this basic genetic test is very important, and before going to clinical exome sequencing, always try to consult one medical geneticist. It's very important. Otherwise, you will do a genetic test, say 10,000 to 15,000, again the report is coming as the variant of uncertain significance or not pathogenic. Then you will be in a problem. So, fitting in a specific chromosomal or microdeletion phenotype, like Down syndrome. And what will be the particular phenotype in Williams? Have you seen any cases of Williams syndrome? So yes, elongated faces and some heart lesions. So if you are able to diagnose clinically either any syndrome or the baby's odd-looking face, the baby's face is not normal. It is not fitting in Down syndrome. It is not fitting in say Prader-Willi, but it's not looking normal. Then you have to search for the other clinical clues. Whether the baby is having phenotypically, whether the baby is having macrocornea, whether the baby is having some findings in eyes, hepatosplenomegaly, spinal problem, genital problem. We sometimes misses the abnormal genitalia. So these are very important. Then if you can fit it in some syndrome or there is some syndrome disorder or some specific diagnostic clue, then we will go for conventional, this is karyotypic or fish and MLPA. So MLPA is a very important test for this myopathic lesion. And say the baby is having hypotonia in neonatal period, fair skin baby, again odd-looking face, the baby is completely floppy, hypotonia, the baby is having respiratory distress because of respiratory muscle weakness. What will be the diagnostic clue? Clinically, newborn baby presenting with hypotonia, poor effort in respiration, fair skin, odd-looking face, feeding difficulty. Any other thing? Yes. Huh? Okay. It's not present tongue fasciculation. If it is tongue fasciculation, then what will be the diagnosis? SMA, spinal muscular atrophy. Then you have to send for MLPA. Karyotyping cannot detect SMA, not even the clinical exam. We have seen cases not diagnosed with clinical exam. In Kolkata, the child had to go to Delhi for a diagnosis of SMA. So now the awareness is increasing. We think there are lots of babies with clinical diagnosis of SMA are coming within very early period with a perfect report from MLPA. So what will be the other cases? Very good SMA tongue fasciculation. If it is not present, then Tituria is not very common. I have not seen very few cases, only 2 cases I will follow up. Any other thing? Hypotonia, fair skin, odd-looking, any syndrome? It's a Prader-Willi. One is Prader-Willi. And sometimes this storage disorder, Pompe's disease, may present with floppy baby at neonatal period. So Prader-Willi is again very important. It's a clinical diagnosis. And you have to confirm the diagnosis by specific test. It is not karyotyping. So, unless we will be very sure that it is the clinical phenotype, then you have to give some clues to the geneticist who is actually doing the test and they are the non-medical person. So, if we are not providing with enough clinical data, then chances of misdiagnosis and missing diagnosis will be higher. So you have to search for clinically. So it is a Prader-Willi. Fitting in specific, the second column now, fitting in the specific single gene disorder. Fragile is very important. Fragile and Rett syndrome, they are having a typical faces and typical presentation. So how the, both are X-linked. So how the Fragile X will present? It is the common causes of global developmental delay and common chromosomal disorder with developmental delay is in which condition? Common, yes, Down syndrome, and common causes of global developmental delay is the Fragile X. It is X-linked. Female may also suffer from Fragile X. So what will be the clinical presentation? Again the elongated face, there will be the prominent ears, intellectual disability, and yes, macrotestosis. So then we have to send for a specific test. Definitely it will not be karyotyping. So specific test for FMRI gene to diagnose Fragile X and Rett syndrome. It is also again X-linked. So what will be the presentation of Rett syndrome? Again female baby. Neurodepression. So the child will, in the later after pregnancy, the child will have regression in all these milestones, especially speech language. And it is a typical behavior with abnormal hand function. Rett syndrome will have a stereotype, hand movement, and regression of the head growth. So there will have the static head circumference. And it is gradually declining, then it will go in a static course in later half of his childhood. So it is Rett syndrome. Rett syndrome, if you can diagnose from this typical phenotype, typical history, and this stereotype movement, then you have to send for a specific test for Rett syndrome. It's not again stereotyping, not fish or MLPA. So sometimes neuroregression may be some congenital condition may mimic neuroregression. That is type 2 SMA. Sometimes they are coming to us that my child able to sit at 8 months of age. Child is now 24 months, but the child won't be able to stand up or walk. The child has attained milestone till independent sitting with good control, trunk control. But at the age of 18 months or 24 months, the child is having motor delay in the form of independent standing and walking. So if you just take the history, it will look like a neuroregression. But it's not like, it is a type 2 SMA, and when you are going for a good clinical examination, what will be the clinical examination of SMA? Hypotonia. All the group of muscle from neck, trunk, limbs, and anything else, trunk articulation, and there will be almost absent jerks, and there will be no anti-gravity movement if the baby present too early, around 3 months. So specifically we will see these type 1 cases, there will be no anti-gravity movement, because from 3 months onward you will get beautiful anti-gravity movement and midline movement with both arms. Trunk fasciculation will appear late, and there will be problem in the respiratory effort. The baby will have difficulty in breathing and swallowing. So SMA may present as like regression. Then the third column, unexplained GDD with and without any focus, sometimes may present as autism, dysmorphism, but the baby is not showing any clues of chromosomal disorder or a particular disorder like Fragile X, Rett, Prader-Willi, or any like known genetic disorder. Any type of global developmental delay where the clinical examination is not conclusive, then we have to go for microarray. So what is microarray? It is a submicroscopic deletion or duplication that can be picked up by chromosomal microarray. So it is not easy like karyotyping. You are not getting any clinical or genetic clue on the phenotype examination. Lastly, unexplained global developmental delay with normal CMA and with or without dysmorphism. There is family history of any monogenic disorder. If it is suggestive, then we have to go for exome sequencing. But see, it is the last column. Always try to be very honest to your clinical diagnosis and to the parents also, because it is more than 10,000 clinical exome sequencing. And only when you will have a strong suspicion that we will get something in clinical exome with say with CNP, then just go for clinical exome. Otherwise, always try with the basic genetic test, and always try to correlate with your clinical and neurological findings with your suspicion. So this is international guideline. Again, this genetic syndrome test for this Fragile X, Rett syndrome. Tuberous sclerosis is not very uncommon. We have some few cases in follow-up. Tuberous sclerosis, how it will present in neonatal period? Tuberous sclerosis from this right side. Tuberous sclerosis. And before that, antenatally, what will be the clues? any prenatal abnormal anomaly scan? Yes, very good. Rhabdomyoma. So there will be tumor-like mass in our antenatal ultrasound around say 20 to 22 weeks, which is a clue for tuberous sclerosis, and the CNS will come later. So there is a specific TS1 and TS2 gene for confirming your diagnosis, but it is clinical diagnosis tuberous sclerosis. So how our genetic diagnosis will help? There is a particular treatment, anticonvulsant and sirolimus. So second line is it is unresolved clinical findings. Then you have to look for whether there is a seizure, developmental regression, hypotonia or dystonia, poor growth, abnormal head size or shape, congenital anomaly of limbs or urogenital system. Then we have to go for the specific genetic cells test like the sequencing, chromosomal analysis, mitochondrial DNA testing. Sometimes very important, we will get a clue, global developmental delay, refractory seizure, and there is a clue from MRI and MRS. So there will be abnormal metabolite in MRS in basal ganglia. So always try to look for the abnormal movement, because sometimes we will get the post seizure like myoclonic movement in early infancy, or sometimes we are getting neonatal period abnormal movement, high lactate, and in MRI there is an abnormal focus in the basal ganglia thalamus. So especially for us pediatrician, these globus thalamus and basal ganglia, these two are very important, one for perinatal asphyxia, this putamen, and one for acute bilirubin encephalopathy, that is globus pallidus. But for the neurologist, it's important for mitochondrial myopathy, myoclonic epilepsy, and so on. So there is a very difficult to control seizure and global developmental delay as well. There is a evidence-based guideline. So there is UK, USA, Irish, and Australian. Actually, the first trial test in UK current this guideline was definitely karyotyping and Fragile-X, and all other guidelines starts with microarray in global developmental delay if the child is not showing any abnormality in the chromosome or a single gene disorder. So what is the advantage and disadvantage of microarray? Advantage is definitely yield is higher, but higher sensitivity in submicroscopic deletion. This deletion cannot be diagnosed by our conventional karyotype. While multiple congenital anomalies are present, multiple system anomaly, then the yield of this CMA will be higher. So it's around 8% to 20% depending upon the population. Disadvantage again for mild familiar intellectual disability, CMA may not be helpful, will not detect condition where structural changes in the chromosomes, chromosomal anomaly cannot be detected, and if there is loss or gain of genetic material such as valence translocation or inversion in chromosome, low level mosaicism that cannot be detected, and cost is higher. It's around 9 to 10,000 CMA. So it is sometimes prohibited. Now karyotyping. So for us pediatrician is very important. It's around 2.5 to 3,000. But before sending a karyotyping, you have to be very sure that you will get something. Karyotyping is recommended instead of CMA for clinically suspected aneuploidy like Turner, trisomy 21, 13 or 18. And if a family history for chromosomal rearrangement is present, there is multiple fetal loss. So there may be some translocation, unbalanced translocation in the fetus, and there is a history of multiple pregnancy loss. Then karyotyping, we will have our genetic consultant is here. She will be elaborating what will be the findings and where karyotyping will be helpful. In LMIC, karyotyping is in selective cases is the most cost-effective tool. Disadvantage, again, it is not recommended as a first-line test in all the international guidelines because its sensitivity is less than 1/2 that of CMA in children with global developmental delay and intellectual disability. Now, what is the role of karyotyping in our population? What is the indication rather? So, if clinically we will get microcephaly, brachycephaly, dysmorphism, hypotonia, brain atrophy in MRI, epilepsy, and for family history, perinatal history, history of pregnancy losses, then it will be very much helpful. Indication positive yield of karyotyping in dysmorphism is again Down syndrome, it is the highest. In one study, it was around 60% global developmental delay. The population was having Down syndrome. So, very well you can diagnose with a simple karyotyping. Structural chromosomal anomaly, marker chromosome. Sometimes there is a very subtle dysmorphism and some marker chromosome are present, then it will be very well picked up by karyotyping. Sex chromosome abnormality like Turner and Klinefelter. Turner and Klinefelter is a clinical diagnosis and you have to confirm with karyotyping. So these are the subtle dysmorphism. So this is again from a low resource country, from Egypt. They have done this study, just sending one genetic test in a cohort of global developmental delay. And the last one is a Fragile X, this older side, and all this G is showing what is the clinical condition in G. Fit, it is the fit with edema. So what will be the likely diagnosis? Turner syndrome. And H is low hairline and waving. So sometimes in neonatal period is very difficult, but the clue is widely spaced nipple, disproportionate stretcher, and this low hairline. And feet is very important. We had one case, it is a low risk pregnancy, primary mother, and it is a edematous feet, nothing else, and that tend to be Turner syndrome. So, marker chromosome is very important and picked up by karyotyping. Now, these are all again these subtle dysmorphic sign and all were diagnosed with karyotyping. These are all very subtle abnormalities with some abnormal dysmarker or inversion, but always look for the baby's face first. Sometimes you will miss if you are not very careful in your OPD practices to pick up the subtle dysmorphism from our day-to-day clinical examination before going to the neurological examination. So, higher genetic testing is definitely clinical exam, but before going for that, try to consult some clinical geneticist. So, specific genetic tests, say in some micromolecular disorder or lysosomal storage disease, we have picked up one is likely lysosomal storage disorder, enzyme is also low, say Gaucher disease, and there is targeted sequencing, only the GBA gene. So that is you can do by sample sequencing. Otherwise, you have to look for the entire exome by clinical exome. So clinical examination, enzyme assay, TMS and GCMS result will navigate you. So what you will try to look for and which type of genetic test you have to go for. So Fragile X we have already discussed. Rett syndrome, this is again some common X-linked disorder. There is a typical phenotype, there is a chart, it's available. This is a comprehensive evaluation of the child with ID. Now, I will call my colleague Dr. Manushi Purokar. This is 2 case study from our clinic. So, this baby, recycling neonatal age group picture. So, what is in the baby's face? So, it's not very typical dysmorphism, but the nose is not normal and there is some type, it's it's not looking normal, but it's not very overtly dysmorphic. So, how we approach the case? She will tell you. So, this baby, I am just starting with the history. Dysmorphic baby, lower developmental delay. The baby later he was admitted in our pediatric OPD with some diarrheal episodes and incidentally found to have hypocalcemia, and the baby had cyanotic heart disease (VSD). Then, because the baby had lower developmental delay, some started dysmorphism and hypocalcemia. They started for looking Geiger syndrome and sent on MLPA in our institute, and that was a negative result. Then how our approach was?
Good morning everybody, I am Dr. Manushi Prasad. This case first was presented in our OPD from Pediatrics Medicine, SSKM hospital. That they suspect this case was the baby was a history of recurrent respiratory infection. That's why they suspect on USG there is a thymic hypoplasia and hypocalcemia was there. So they suspect that this is the case of Geiger syndrome, and they have done there is a microarray, but there is no not detected. Geiger syndrome was not detected, but there is duplication of the chromosome 13, the 13q23 region. And now we have seen that the baby was 6 months old and developmentally delayed, and there is facial dysmorphism. Mainly there is one clue that the extra finger in both hands, and there is the evotic nostrils and dark nose and periorbital puffiness. Nothing I have had there. But we sent first karyotyping because there is a 13q duplication, but no clue that what it is. So I sent karyotype and found that there is a chromosome 13, there is a present, but we are very surprised that chromosome 13 survived up to 9 months of age. Now the baby is 1 year, 2 months old. There is developmental delay, but till now she survived. Yes, trisomy 13 unusual presentation. Actually, infant date usually occur. I suspect that usually there is a duplication, but total 13 genes was not duplicated. That's why she survived.
So, karyotyping was diagnosed, not this MLPA and sequencing. So, this is the beauty of karyotyping. So, now the second case, another case, it is a dysmorphic phenotype and presented with developmental delay.
This baby delivered here with some facial dysmorphism, and hypotonia was there, and there is a birth asphyxia actually delivered outside the SSKM hospital, admitted here for respiratory distress, and they are diagnosed as birth asphyxia and discharged here on day 13 of life. And she came to our hospital 3 months of age, and I saw that there is some facial dysmorphism, that is the prominent elongated symptom, thick lower lip and periorbital puffiness and inverted nostril, and there is a clinodactyly. Otherwise, there is nothing found. That's and already some doctors suggested whole exome sequencing from outside, and they found nothing. Then go for microarray. There is a 13 duplication, and also they suggested 4 chromosome loss from the chromosome 4 and duplication from the chromosome 13. And we go for karyotyping, and also her father have balanced translocation from the chromosome 4 to chromosome 13. But this is a balanced translocation, and there the baby's chromosome where there is a chromosome 13. Not there. 13 is here, and there is the extra part in the chromosome 4, but not in here. In karyotyping, not there is a chromosome 13, but part of the chromosome goes there in the chromosome 4, and that's why microarray showing that the extra loss of chromosome 4 and duplication of the chromosome 13. That is also the partial trisomy 13. And also she is suffering till now. 9 months old. Help.
Developmental analysis stereotyping was absolutely normal, but his father had balanced translocation, but in offspring it was unbalanced. So the baby presented with dysmorphic faces and delay, but the father was absolutely normal. So this is actually the need for stereotyping. So this is. So key messages we have already told several times, all these speakers, because most important is the clinical examination and stepwise approach. For genetic disorder also, this stepwise approach is very essential rather than jumping to a very costly investigation, thinking that higher cost means the maximum rate. It's not true. Thank you very much.
Like whatever we read in theory is not what happens. Patients don't read the LSL, patients don't read the protocols. Patients come with their own signs. We have to fit in their signs and symptoms by analyzing in our way in a systematic. Okay, so next, Dr. Shankar, would you like to comment?
Yes. Thank you everyone for all the lectures right from the morning were extremely informative, from all theoretical and semi-practical discussions. We will be right now in the field to play the actual game. So we have two beautiful cases for presentation for this purpose. They will be presented by Dr. Mukherjee and Dr. Arundhati Banerjee. None of them will give an introduction. So may I request motion? Either you or Arundhati.
We have just cases for you. You know the approach now. And just give you the cases. Yes. She said,
So a very good morning to all of you. After that wonderful session amongst eminent speakers, I stand here and I feel thankful to the organizers for giving me the opportunity. So here, after all the stepwise discussion that has been done, now I would like to present a potpourri of clinical pearls, the cases that I encountered in my clinical practice. There will be 5 of them, but they are just short descriptions, and then it is expected that you sit back
Then we did an ammonia that was not very distinct. We did a homocysteine in order to rule out the MMA-CHC group. Those were also normal. So, neuroregression, large head, dystonia, distinctive MRI change. We did a TMS, analgesics, and that did the diagnosis. Genetics was not done due to constraints of economic constraints. So, here in TMS itself, we had an increased glutathione carnitine, TRLC X9 carnitine, which is less to the glutaric acid
clinical photographs which we have, you can appreciate the chaotic lesions and also the contractures which were dynamic. The child was even unable to walk. There was spastic diplegia mode, but of course spasticity was also there in the upper limbs. So the possibilities we thought of is, one is Sobret-Larsen syndrome. This is again a metabolic disorder, fatty acid aldehyde dehydrogenase deficiency, which can present with spastic quadriparesis, but then you have mind pattern changes, and of course biotinase deficiency, late onset as I said. Then we went ahead with investigations. B12, homocysteine, they were normal, and biotinase level was also elevated. It was not low, and we did a CK match that was elevated, possibly due to some muscle involvement. Then what we found was these are the images, the T2 axial images showing involvement again of the globus, bilateral globus pallidus and the periventricular and the subcortical white matter, which was involved. So white matter changes are very characteristic of Sobret-Larsen. So white matter changes with spastic diplegia with ichthyosis. Think of Sobret-Larsen. This is not a cerebral palsy. So these are again cerebral palsy mimics. So please try and develop an eye for these patients. So MRS gives a clue. So in 1.3 ppm you can get an aldehyde and alcohol peak, and which is also found as smaller peak in 0.8. And of course we did a genetics also. ALDH3A1 was also likely pathogenic. So possibly this child is suffering, but of course unfortunately for the child, this is not one of the treatable entities. Had it been biotinase, I would have been happier because the child would have been offered a therapy. But here again, the child is on follow-up with the supportive therapy. This child also has epilepsy. So these are some of the representative pictures of patients, not our patient. And these are distinctive signs: periumbilical hyperkeratosis with radiating furrows, which is important. Spasticity appears before 3 years of age. Seizures are present. 1/3 of the patients have perifoveal glistening dots in the ocular fundus. So if you can have a fundus evaluation, maybe that can also help before going to genetics. So this is what a fundus photograph looks like. These are again the representative pictures. Coming to the last case, Mohini, 11-year-old girl, presented with chief complaints of again premorbid delay, loss of previously attained milestone since 5 months of age. Born to non-consanguineous parents, second in birth order, normal perinatal period, developmental delay, no family history of similar illness. So this is a child, there was normal head size, but as ma'am had
Enzyme replacement in UPS.
Enzyme replacement, like polysaccharide and all that, it started early enough. I've seen presentations from experts who have shown us how the child is actually mothers and doctors, they've actually grown very well and doing a job or something that were diagnosed early. Also many stem cell therapy, bone marrow therapy, they're all coming up in big active therapies. Even pushing and all, so we can really at least give them a greater quality of life by giving these replacement therapies or active therapies. So this is a frontier
vegan. Was he vegan?
Yes.
Was the child vegan?
Yeah. Not a vegetarian.
No, vegetarian do not.
vegan না দুধ খায় কিন্তু বাচ্চাটা মায়ের দুধ খেত কিন্তু মাও তো মাকে আমরা দেখেছিল মাদের অলসো আই
Because vegans usually suffer from visual or after stomach surgery.
Yeah, but no, this time they were vegetarians. Vegan and vegetarian difference is vegan don't even have cows.
But might be interchanging. Sometimes they come from vegan, sometimes vegetarian.
Yeah. The mother, they were all the vegetarian family, Yoshino family, and mothers vegetarian people, they were also the child was breastfed for a long time. And again,
You are given parental vitamin B12 or oral.
so there is, I don't want to go into it, there are both, literature says both are there, oral effective, IM effective, but we need to give parental initially.
Now, but if you have any doubt about the factor causing the vitamin B12 deficiency, if the child is on vegan diet, then definitely it is a deficiency in the diet.
Yeah,
but
that's
if the child is vegetarian, there is no absolute deficiency of vitamin B12 because there is enough source of B12. So, see, in those cases, there might be some possibility of vitamin B12 absorption. Even if the child has not been operated on the stomach area. So what was your mode of treatment? Was it parenteral vitamin B12 or oral?
But even in nutritionals, now there is literature to say that oral also works. But we gave 1,000.
No, I'm talking about nutritional due to malabsorption, not from the source of diet. সেটাই বলছি আমি সেটাই বলছি
আমরা আর বেশি ইনভেস্টিগেট করিনি আমরা এখানে ওকে দিয়ে দিয়েছি প্যারেন্টাল তারপরে ওরা দিয়েছি আচ্ছা এটা তো আই থিংক এটা সবার বলা উচিত আমি এটা বলবো এনি চাইল্ড হু ইজ হ্যাভিং পোস্ট ফেসেস হেপাটোস্প্লেনোমেগালি in 6 months 8 months what it would be mucopolysaccharidosis that is what I want to say thyroid, hepatosplenomegaly, I'm saying. So any child below 1 year of age looks like a mucopolysaccharidosis, more likely muconucleosis. Okay. Any child beyond 1 year of age looks like a mucopolysaccharidosis, most likely mucopolysaccharidosis. This is a, I think, 9-month or 11-month-old child, and you can see that the closeness is there, really well established. So we are talking about the case with immunity has also shown. If this child came with developmental delay, always irritable, itchy, crying, no convulsions, looking close like this, and you can see that it will be marked out that there is a hepatomegaly. And this is what she said, which is an excessive thrombotic response. So again, the issue was genetic tests were expensive. They were from a Muslim family. So immediately you feel difficult looking at their condition, translate to somewhere because we had to treat it. So what we did was, there was a plan, but we never got into the plan. We did the eye check, and this is what we got the genetics. So what we are talking about? GM1 genetics. Okay. So we don't know in future if there is some enzyme replacement. So that is why we always try to diagnose where possible. What is not diagnosed today, and what is not able to be diagnosed. So thank you for your patient hearing, and that brings us to the end of the first half of lectures. So now I would request you to stay here. We have a recitation of the
First.
গ্লোবাল ডেভেলপমেন্ট রিলেটিভ যেখানে আমার এই ওভারঅল ডোমেনগুলোতে ঘাটতি হচ্ছে। তাহলে বাচ্চাটা ওভারঅল ডিলে নিয়ে প্রেজেন্ট করছে, প্যারেন্ট এসে আমার বলছে আমার বাচ্চার ডেভেলপমেন্ট বাকি বাচ্চার মতো হচ্ছে না। সো ফার্স্ট আমি
She can also carry the baby on her waist. বলে কাঁখে নেওয়া যাবে বলে এইভাবেও বাচ্চাকে নিতে পারে, তাহলেও এই অ্যাডাপ্টার টোনটা করবে। আর প্রপার সিটিং এনহ্যান্স করার জন্য পিলোস দিয়ে এইভাবে সেট করতে হয়, তো আমরা সবাই বলে থাকি যে পিলোস দিয়ে সেট করা। আরেকটা বলে রুমের কর্নারে নিয়ে গিয়ে বসা, যেখানে এইরকম একটা সেট আপ আছে which will give support to the trunk of the baby, সেই রকম একটা জায়গায় ওকে নিয়ে বসানো, আর সামনে কিছু এমন টয়েস দেয়া, সফট টয় বা কিছু, যাতে কিনা এরকম দিকে না। আর কিছু ইন্টারেস্টিং বা ছোট একটা স্টুলও হতে পারে যার উপরে ছোটখাটো খাইলা দেওয়া থাকে, which she will try to manage. তাহলে this will enhance the truncal support and this will lead to enhanced sitting rest. এটা গেল সিটিং। এখানে কি কি আর ছবি আছে? এখানে একটা দিয়েছে যে মা শুয়ে, বাচ্চাটা শুয়ে রয়েছে, মা ঝুমঝুমি বাজাচ্ছে, বাচ্চাটা ঘাড় খোলার চেষ্টা করছে। That also increases the neck control. This hammock can be used in case of hypertonia of the trunk. মানে এরকম একটা ক্লথের একটা আপনার একটা দোলা বানানো যেতে পারে, on which you can বেবিটাকে শুইয়ে দিলে ট্রাঙ্কের হাইপারটোনিয়াটা কমবে। মানে এইগুলো একটা সিম্পল ম্যানুভার যেটা ওর মাদার ক্যান বি টট এন্ড শি ক্যান ডু এট হোম অলসো। নেক্সট হচ্ছে গ্রস মোটর স্টিমুলেশন এর
extensive. Here you see the pedigree. You see these dots will not be there. Dots won't be there. Okay? Only affected people will be there. So here again, it is that usually males are only affected. However, there is something called and so manifesting heterozygotes. That means very rarely there can be a really girl. But again, for them the severity to his son, but the daughter. In X-ray recessive, none of the boys will be affected in case of an affected father. All his daughters will be carriers because he has only one X with one mutated. Okay, so whatever contribution he has to the zygote formation, it will be carried. Okay, so actually what happens is we do not get such extensive families. We usually get apichelea. Our chile কোনো অসুবিধা নেই. That mother does not know that she maybe she has a DNA mutation. This boy has escaped. Okay, she has one daughter. No one has tested her. She gets married. Her boy can have her because no one has tested her for her carrier status. Okay, so unless and until the extensive family, 4-5 members per couple, the other
input processing output, the rest is formalizing, and the rest is about guiding the parent by তোমার বাচ্চা এখানে আছে, and for whatever is the scenario আর next level এর বাচ্চাকে নিয়ে যাওয়া সম্ভব। এটা সম্ভব না বাচ্চাকে 10টা স্টেপ ওখান থেকে কিন্তু ডিপেন্ডিং অন হাউ আর্লি দে কাম 10টা স্টেপ সম্ভব হতে পারে। সো ইটস অ্যাবাউট হাউ আর্লি ইউ আর ইন্টারভিউ। নাও আমরা যখন ডিসেবিলিটির জন্য অ্যাসেস করছি আমরা আইকিউ স্কোর থেকে গ্রেড এসকিউ আইকিউ হোয়াটএভার আমরা ওখানে কতগুলো আইকিউ রেঞ্জেস পাই যে বাচ্চা এখন এখানে আছে। অলরেডি এখানে বলা হলো যে 5 বছরের মধ্যে 5 বছরের the rest is about training them so that they can এখন পর্যন্ত বললাম does it make sense? এবার এতক্ষণ আমি বলি আমার বলুন যে where do you think you need support যেখানে এই জায়গাটা বুঝতে then when it comes to intervention, first is empowering the person. যখন আমরা থেরাপিস্টের কথা বলি
আমরা ওই ডাক্তার দিয়ে বা জুসগুলো দিয়ে উইকেট স্টিমুলেটে দিয়ে দেবো। তার সাথে কি করবো, দ্য মাদার উইল স্পিক টু দ্য বেবি, যত কথা বলবে, গান গাইবে, মাকে বলবে বিশেষ করে কথা বলবে, অনেক সময় জোরে কথা বলবে, বাগানে নিয়ে যাবে যেখানে পাখির আওয়াজ হবে, পাখির আওয়াজ এখন শোনা যায় না, যাই গ্রামে গঞ্জে শোনাবে, পাখির আওয়াজ শোনাবে, ডিফারেন্ট ভেহিকলসের আওয়াজ শোনাবে, পাখির ডাক, গরুর ডাক, এগুলো শুনবে এবং ইউ ইমিটেট দ্যাট। গরুটা যেরকম করে বললো সেটা ইমিটেট করে বাচ্চাকে শোনো। বাচ্চার যে স্পিচটা বলছে গাট 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 সেইটা ইমিটেট করে বাচ্চাকে শোনো। বাচ্চা যেটা বাবা বলছে বাচ্চার সাথে সাথে বলো, বাট নেভার ইউজ বেবি স্পিচ। বাচ্চা যদি বলে গৌ হাম্বা ডাকছে তাহলে তুমি কিন্তু গৌ বলে বলবে, তুমি গরু হাম্বা ডাকছে এই কথাটা বলবে। কখনো বাচ্চার বেবি স্পিচ ইমিটেট করবে না, দেন দ্য বেবি উইল লার্ন দ্যাট বেবি স্পিচ।
রসগোল্লা বলা যাবে,
হ্যাঁ রসগোল্লাই বলতে হবে। বাচ্চা যদিও সেটা করে, বাট উই হ্যাভ টু কারেক্ট, উই উইল নট কারেক্ট দ্য বেবি। আমরা নিজেরা যেটা বলবো সেটা যেন কারেক্ট, এই জিনিসটা আমাদের খেয়াল রাখতে হবে। ভিজুয়াল স্টিমুলেশনে কী কী আছে? ভিজুয়াল স্টিমুলেশনে খুব ছোটো বাচ্চা হলে আমরা বলি যে অন্ধকার ঘরে লাইট দেখাতে, তো রিংটাকে ও হয়তো সে মানে এখনো বোঝে না যে কোনটা বড় কোনটা ছোট, সি ক্যান নট স্ট্যাক ইট, বাট শি নোজ দ্যাট দিস টু আর ডিফারেন্ট, দুটোর শেপ আলাদা, দুটোর কালার আলাদা, সেইটা হয়তো এই বাচ্চাটি বুঝতে পারছে। নেক্সট কী করছি? নেক্সট হচ্ছে টাচ সেন্সিটিভিটিটাকে বাড়াচ্ছি। এই যে কি একটা টয় বলে এগুলোকে সবাই মেলা থেকে কিনে আনে, পোক করে সবাই, ঠিক আছে? তো দিস ইজ সাপোজ টু ইনক্রিজ দ্য টাচ সেন্সিটিভিটি। পোক করছে, আবার উল্টো দিক থেকে পোক করছে, দ্যাট ইনক্রিজেস দ্য টাচ সেন্সিটিভিটি। শোয়াতে হবে, মায়ের কোলে শোয়াতে হবে,
তুমি এই যে তুমি এটা সেটা